I want to shift gears a little bit and talk about the evolution of Devi Shetty's model now that it has been shown to be working pretty well in cardiac care, cardiac surgery, cardiology, what have you. You know, when I discuss this in my class at Harvard, immediately there are two qualitatively different options that suggest themselves. One of these is to say, let's take the same idea, the same model of scale-driven interventions, scale-driven treatment, and see if we can replicate it in oncology, in orthopedics, in ophthalmology, what have you. Same idea, just different disease ailments, and the idea of scale and learning over time ought to represent some way of both improving the way in which that care is delivered as well as lowering the per unit cost of delivering that care so that you have a win-win situation in both cases. It also seems that we ought to be able to take the same subsidy model, that is paying patients subsidize less paying or non-paying patients in a way that is possible to do within the total amount of extra value that's created by the efficiencies that the model generates. So that's one option. The other option is no, what we really know how to do is to be very good cardiac surgeons and cardiologists, and the need for that care is rampant across the world. Heart disease continues to be one of the leading causes of death around the world, including in my own adopted country in the United States. And why don't we just focus on that and take the cardiac care model and go to different geographies. We can think about all of Africa, we can think about the rest of Asia, the Middle East, Latin America, what have you. There's a lot of places to take that model and apply it. So just to recap, in one case, you keep the geography fixed, stay within India, just for purposes of tractability, simplicity, and take the model and apply it to different therapeutic settings. In the other case, keep the therapeutic setting fixed, but vary the geographies. Which would you rather choose? Think about it.